So good morning. My name is Lindsay McCary. I'm the director of the Autism and Developmental Disabilities Clinic here and the psychologist within the Down Syndrome Clinic. And so today I'm going to talk a little bit about the co-occurrence of Down syndrome and autism spectrum disorder. We could spend most of the morning talking about the overlap of these two conditions, but this is really kind of a broad overview, and I'll be on the clinician panel later if there are additional questions. So briefly, I'll talk about Down syndrome, which all of you are familiar with, and autism spectrum disorder, what autism spectrum disorder might look like in an individual with Down syndrome, what are some of the risk factors and symptoms, and what does an evaluation for autism entail? So what would you expect if your child is receiving that evaluation, and briefly some recommendations and resources. So all of you are familiar with Down syndrome, but it doesn't hurt to emphasize that Down syndrome is something that can be diagnosed with a specific test. So there's a yes or no answer based on that medical evaluation. Whereas autism spectrum disorder, although we can pretty reliably diagnose this condition, usually we're gathering multiple sources of data, behavioral data, to be able to evaluate whether or not somebody is diagnosed with that condition. In Down syndrome, we know the cause is the presence of a full or partial trisomy of chromosome 21. With autism spectrum disorder, there are many genes that have been implicated in the condition, and we know that there is a genetic component, but we don't understand one clear cause of autism spectrum disorder. In Down syndrome, oftentimes individuals have an intellectual disability that ranges from mild to moderate severity. With autism spectrum disorder, actually a minority of individuals with autism will also have an intellectual disability, and instead we define autism by differences in social communication and social interaction and the presence of some repetitive behaviors. It's important to note that individuals with Down syndrome also engage in repetitive behaviors, even if they don't have that co-occurring diagnosis of autism. So we'll talk more about what that might look like and when it might be appropriate to ask or seek out that evaluation. So I'm going to talk a little bit more about what autism is because some of you may be less familiar with that condition. So to diagnose autism, we use the Diagnostic and Statistical Manual 5th edition. What that is a large resource book that has different neurodevelopmental and psychiatric conditions and defines the symptoms or the criteria that we're evaluating to say whether or not somebody has that condition. And so the DSM defines autism based on these 5 criteria. The first are deficits in social communication and social interaction. So what that means is not that somebody is not interested in social interaction, but how they engage in social interaction or the quality of those interactions might look a little bit different. So maybe they ask somebody to play with them by tugging on their shirt rather than looking at them or using vocalizations. Maybe that individual is less responsive to other people's emotions. Maybe they're not seeking out comfort when they're hurt or are sad about something. So it's how they're initiating interaction may look different. We also talk about restricted and repetitive patterns of behavior. And so what that can look like are things like hand flapping or doing things with one's body. It could be repetitively playing with a toy. It could be having difficulty with transitions or changes in routine. It could be having highly restricted interests, so really liking a specific topic and referencing that topic over and over again. And it can look like sensory differences. So either being over or under responsive to different sensory stimuli. With autism, we expect those symptoms to be present early in the developmental period. So we would not expect these symptoms to first emerge in adolescence or young adulthood. These are things that we're noticing prior to the age of 5 or 6. Often these symptoms are causing impairment in multiple environments. So it's not just somebody who's having some trouble with social interactions at school, but we would see impairment at school, at home, and in other settings. And what's most important when considering autism within the context of Down syndrome is that these symptoms or behavior are not better explained by an individual's intellectual disability or developmental delays. So any differences in social interaction are above and beyond what we might expect given developmental differences. And so we'll talk more about what that might look like. So I show this graphic because it highlights the complexity of autism spectrum disorder, and this is really referencing autism not within the context of Down syndrome. But the dark blue circles represent the core features of autism, and the gray circles represent all these symptoms that may occur with autism. And so similar to Down syndrome, it's a very complex condition, and individual symptoms are going to be variable. So with autism, sometimes there are sleep differences or gastrointestinal differences. There may be inattention or hyperactivity or mood and anxiety disorders. So all of these are factors that we have to consider when evaluating autism spectrum disorder. So just briefly, some information about autism, again, not in the context of Down syndrome. We know that autism occurs in about 1 in 59 children within the United States. It's more common in males than females. About 10% of individuals with an autism diagnosis will have a co-occurring genetic diagnosis. So Down syndrome, Fragile X syndrome, tuberous sclerosis are some examples of that. In children with autism without a co-occurring genetic condition, we can reliably diagnose the condition around 2 years of age, and that diagnosis has shown to be stable over time. That age of diagnosis gets a little bit trickier when we consider co-occurring genetic conditions. And there has been an increase in prevalence over the last few years in autism. So I will say, when we think about autism within Down syndrome, this is an area where there is not a substantial amount of research literature. There are several labs within the country who are starting to study the earliest emergence of symptoms of autism in individuals with Down syndrome, and they do that by studying really young infants and collecting physiological measures and behavioral measures to say, are there symptoms early in life that can help us understand who will develop autism and who will not. But what we do know from the research literature is that those with the dual diagnosis of Down syndrome and autism tend to have greater intellectual impairment. So those autism symptoms aren't solely explained by the greater intellectual impairment, but are shown to be above and beyond those developmental differences. So those individuals are having a harder time with the back and forth of social interaction. In individuals with the dual diagnosis, there are higher rates of stereotyped behavior. So what I mean by that are repetitive behaviors one does with their body, repetitive actions with objects, repetitive use of language. So this can be somebody who repeats the same thing over and over again or has repetitive vocalizations, or somebody who's repeating back what other people say in a non-functional way. So it's not very useful to get what they want. And overactivity or symptoms of ADHD can also be more common in this population. As I mentioned before, when we think about Down syndrome and autism spectrum disorder, we're really focusing on that social piece and what are differences in social interaction. So individuals with the dual diagnosis do have a harder time orienting to social interactions, so things like responding to their name or responding to really exciting things, like if a parent's like, hey, look at that, they might have a harder time with that. They're less often initiating social interactions with other people, so going up to other kids or asking for social interaction with caregivers, and they have less shared affect. So what we mean by that is if they're really upset or scared or really excited, they may be less likely to direct that to another person or to respond to another person's emotions in that way. But again, I emphasize that research is still somewhat limited in this area, and hopefully we'll be able to understand more about what autism looks like in people with Down syndrome as more research emerges. So similar to research on the behavioral phenotype, we have less information about what some of the risk factors might be, but we do know that infantile spasms or seizures early in life can be a risk factor, similar to individuals with autism without Down syndrome. Complications from heart surgery, early hypothyroidism, and being a boy are also risk factors. In autism spectrum disorder without a co-occurring genetic condition, we know that about a third of individuals experience a period of regression or loss of skills around the second birthday, and often that looks like losing some language skills or differences in how they're interacting socially. We do know that the same thing can happen in individuals with Down syndrome, but often there's a greater percentage of individuals with Down syndrome who show this period of regression, and the regression is shown to be later in life. So whereas in individuals with autism without Down syndrome, we might see that around the 2nd birthday, and individuals with Down syndrome, we might see that closer to the 5th birthday. And this is really important because if we're monitoring early development, we may need to screen for symptoms of autism later in life. So for individuals without Down syndrome, we usually screen at 18 months and 2 years of age. For individuals with Down syndrome, we should continue to be screening for symptoms of autism so that we can catch individuals who may show these differences. So when to ask the question? I would say as a clinician that whenever you as a parent or caregiver are concerned that these behaviors may be present in your child, you should be asking the question because it never hurts to go through these evaluations to make sure or to better understand your child's strengths and weaknesses. For all of us as clinicians, we can sometimes attribute behaviors to what is known about an individual. So what that means is in individuals with Down syndrome, since we know some of these behaviors are part of Down syndrome, sometimes clinicians will say, well, the symptoms that are being described are because they have Down syndrome. And so we as clinicians always have to remember to look at all the possibilities and evaluate for other conditions as necessary. So oftentimes we're relying on the parents and caregivers to let us know when they've seen these patterns of behavior in other settings. And when we think about autism in Down syndrome, we're really focusing on the absence of certain behaviors rather than the presence of other behaviors. And what I mean by that is I, as a clinician, am less concerned about a child with Down syndrome who engages in hand flapping because we can see that in Down syndrome. I am more concerned about an individual with Down syndrome who's not initiating or responding to those social interactions. So that lack of social engagement versus the presence of repetitive behaviors. Both are important, but helpful to tease apart those symptoms. So what does an evaluation for autism entail? For individuals, all individuals, but especially those with genetic conditions, it's really important to have a good medical evaluation first to rule out any other medical conditions that may be causing or mimicking symptoms of autism. So in Down syndrome, we think of things like obstructive sleep apnea. That might lead to different behavioral changes that might look like autism, but understanding that or treating OSA can help us tease that apart. Ideally, an evaluation is with an interdisciplinary team. So we want a physician, a psychologist, speech pathologist, OT, social worker, kind of a variety of different professionals who are working together to best evaluate the strengths and weaknesses of the individual. Sometimes accessing an interdisciplinary team can be challenging, so if that's not available, I do want to talk about the components of an evaluation that are really important. It's very important to understand somebody's cognitive or developmental functioning because we are going to compare social skills to what their developmental level is. So what I mean by that is for an individual who's maybe 6 or 7 years of age, but developmentally is functioning more around that 3 or 4 year level, we want to compare their social development to that 3 or 4 age equivalent, not to the 6 or 7 age equivalent. So having a good assessment and understanding where that developmental level is very important. We want to be able to understand adaptive skills or daily living skills. So how is an individual functioning within their environment? What are their language abilities? And with language, we're thinking about how they use language, how they understand language, and the social components of language or the pragmatics. And when evaluating for autism spectrum disorder, we want to be using standardized tools. And so some of you may be familiar with the ADOS, or the Autism Diagnostic Observation Schedule. ADIR and CARS are some other tools, but they're really useful tools that have been validated to really get a good sense of symptoms of autism. And as I mentioned briefly before, we want to consider somebody's developmental trajectory or developmental course as we tease apart other explanations for behavior. So in an adolescent who all of a sudden is showing symptoms of withdrawal or is not being as socially engaged as they were in the past, autism may not be the best explanation for those behaviors because they represent a change from that individual's kind of baseline. So in those cases, we might consider other explanations for behavior, such as things like anxiety or mood disorders, other underlying medical conditions. So we really want to have a good sense of kind of this individual's baseline or typical functioning. So some families will ask, why does it matter? My child has a diagnosis of Down syndrome, and from that they're able to access intervention services and school services. So what does this additional diagnosis provide, or how is it useful? I would say that most developmental issues likely are similar, but the targets of our intervention might look different for individuals with this dual diagnosis. So with autism, since we know one of the core features is social functioning or social interaction, we may target some of our interventions to address those skill deficits or skill weaknesses. So maybe the focus of speech therapy or IEP services shifts a little bit to have more focus on that social piece. There may be additional medical workup that's recommended within this context, and there may be increased social support available. I can't emphasize enough that it is helpful to connect with other families who also have a child with a dual diagnosis and to be able to share in that experience. So what's next after receiving a diagnosis of autism? Again, the need for family support is really important, and there are some great resources out there that I'll share with you for connecting with other families or people who have experienced this dual diagnosis. Specific to the diagnosis of autism, some families will choose to initiate ABA therapy or applied behavior analysis, which is considered the gold standard treatment for symptoms of autism. And so what that can look like depends on a child's age and the other services that they're engaged with. But typically for very young children who are not yet in school, ABA therapy can be a very intensive model, somewhere between 25 to 40 hours a week of one-on-one intervention with a therapist to help address some of these social skills and repetitive behaviors. As children enter school age, the therapy becomes less intensive because they're in school and have other activities, and so it might look like 10 to 15 hours of individual therapy. It's important to communicate findings with your child's school team and other professionals who are working with them, again, because the goals of treatment may be shifted based on this new diagnosis, and of course, communicating with your child's pediatrician or primary care doctor. So I do want to share some really useful resources that are available both for individuals with Down syndrome and autism, but also just individuals with Down syndrome alone. So the first resource is called When Down Syndrome and Autism Intersect, a guide to Down syndrome autism for parents and professionals. And this is a really helpful resource for families and professionals to better understand this dual diagnosis and the co-occurrence. The book is written by a family member and a medical professional, so there are some nice family stories and some resources around things like dental care, IEPs, and other intervention services. So this is a really nice resource that's available. The second resource is Supporting Positive Behavior in Children and Teens with Down Syndrome. And this book is written in general for individuals with Down syndrome and how to support more positive behavior. How do we intervene on some of the more challenging aspects of behavior? And then finally, the Wisconsin Regional Centers for Children and Youth with Special Healthcare Needs is a great first step. So if you're considering whether or not an evaluation is appropriate for your child, the regional centers can help direct you to resources within your community, as well as if you're seeking additional treatment resources or family support groups. This is a resource available to people throughout Wisconsin. I included the information for the Waisman Center clinics, and I do know that there is a family group sponsored by Mads and Gigi's Playhouse for individuals with the dual diagnosis. And additionally, there are some online resources that are specific to autism, but they're free and available for individuals who are interested in learning more about intervention resources or how to implement some of these strategies within your daily routines. All right, so are there questions? Mm-hmm.
My name is Nancy Aylar, and I'm currently the president of the Madison Autism, the Autism Society of South Central Wisconsin. And one of the things that's always puzzled people in the autism community about the DSM-5 is the complete lack of coverage of the sensory issues surrounding autism.
Mm-hmm.
And could you address that? Because I noticed that you also, in your slides, do not talk about that. And that's something that autistic adults talk about all the time.
Mm-hmm.
And I think it's a significant thing for anyone working with someone with dual diagnosis.
Mm-hmm. Great. So the question was about the sensory aspects that commonly occur in individuals with autism and whether or not that's addressed within the DSM. So the previous edition of the DSM-4, did not address sensory needs of individuals with autism as part of the core symptoms. But in 2013, the newest edition of the DSM was released, and sensory needs are part of the core symptoms. They fall under the category of restricted and repetitive behaviors. And so an individual who has high sensory needs or sensory aversions, that is part of the diagnostic criteria. Yeah.
And could you just briefly address what that might look like
Uh-huh.
for someone with Down syndrome and trying to, think about that?
Mm-hmm. So kind of what would that look like for somebody with Down syndrome? And it can present in a variety of different ways. So for some individuals, they really do not like certain sensory input. So it could be a difference with tolerating food textures or clothing textures, having difficulty with public toilet flushings, things like that. Or it could be somebody who really seeks out that sensory input. So for some individuals, they might enjoy heavy work, so maybe pushing furniture around, or they like to create a lot of noises with toys because they're really seeking some of that sensory input. So, and some individuals can have sensory aversions and sensory seeking behavior together. Other questions?
Can you go back 2 slides just for a minute?
Yes. And I think these will be available on the website as well. Yes.
Could you talk more about the incidence? Your statistic was a lot higher than what we typically hear.
Yes. Yes, so you're right, I did not touch on that. So the range of prevalence of the occurrence of autism within Down syndrome is somewhere between 5 and 39%. And the reason there is such a range is because there haven't been a ton of studies really thoroughly evaluating the prevalence. And so the range is based on the study sample and how a study chooses to diagnose autism and what tools they use. So it is a broad range because we don't have as much literature to kind of narrow that down. Some people will use the estimate of around 10% of individuals with Down syndrome will have this co-occurrence. So it is something we're still trying to learn more about, of exactly what percentage of individuals will have this dual diagnosis. Mm-hmm.
You had a couple of slides of information on intellectual development and IQ.
Yes.
And oftentimes there is a stigma regarding that intellectual development and IQ.
Mm-hmm.
Are you saying there that basically a person who has a dual diagnosis or even a single diagnosis, that their intellectual capacity would be general to anybody else in society, that we all have the various IQs, or what do you mean by that?
I'll try. I think I understand your question. So we do all have a variety of abilities when it comes to intellectual functioning. And for most of us, when we think about autism, we're comparing those social behaviors to that intellectual functioning. So that is not necessarily specific to Down syndrome, but because individuals with Down syndrome may have some developmental delays, we want to consider that when we're thinking about their social interaction skills, so that we're kind of being thorough in our evaluation of those abilities. And IQ, when I talk about IQ or cognitive development, it's not just a score on an IQ test, although that can be useful information, but we're also thinking about how somebody is getting around in their daily life. So how are they functioning out in the community, and what are supports that they might need in that area?
You said that kids with autism, they have
Mhm.
and with kids with Down syndrome, that'll be around 5. Do you guys prefer to evaluate a Down syndrome child at the age of 5 or more to have a dual diagnosis, or
So that's a good question. It's really about the age of diagnosis of autism within Down syndrome, and it can vary. So for some individuals, it may be that those symptoms are pretty clear less than 5 years of age, in which case we would want to pursue that evaluation at that time. But because it can be more complex or a little bit harder to diagnose, it may be that individuals are identified a little bit later. And I want to clarify, too, that not every individual with Down syndrome with this co-occurring diagnosis will show a period of regression. About half, from what we know in the literature, may show that. So I think we have time for one more question. Yes?
Well, can you see in an MRI a different configuration?
So I don't know that that has been studied specifically within Down syndrome and autism spectrum disorder. There have been MRI or imaging studies in individuals with autism, and there's kind of a variety of different brain imaging findings, and so I'm happy to connect with you after and kind of talk a little bit more about that. All right, thank you.